So our next paper is surgical treatment outcomes for axillary-subclavian vein thrombosis due to venous thoracic outlet syndrome. This will be presented by Dr. Esmail Dadashida from Washington University, St. Louis, Missouri.
Thank you very much. My name is Reza. I'm a second-year fellow at Washington University, and I'll present our institution's treatment protocol for venous thoracic outlet syndrome and the results. We have nothing to disclose. And as you'll see, a very similar protocol to the team from St. Joseph. When I started my fellowship a little over a year ago, I started on the thoracic outlet service, and I learned quickly what our protocol was. Prior to making skin incision, we place a bacillic sheath, and we shoot a preoperative venogram just to assess the situation. As you can see from screen left to right, we get an idea of what to expect. On the left, we see focal stenosis, possibly amenable to patch angioplasty. The next one, we have a focal occlusion, either a bypass or a patch. Then sometimes we see long occlusions, likely bypass candidate. And finally, there are instances as well where we see chronic occlusion with no amenable inflow vein to perform a bypass. Now, these are all before our decompression, so often we will see that after decompression, we have a more favorable venogram with a more favorable option for direct venous reconstruction, which is what our institution prefers to perform. Here's an example of one of the 4 possible outcomes after decompression, where we have a patent vein. And sometimes we have that focal stenosis where we perform a patch angioplasty, given that we have direct surgical exposure, as opposed to performing any sort of endovascular procedure at this time. And then when we have a much longer segment occlusion, we will prefer to perform a bypass. And finally, unfortunately, there are instances where even a bypass cannot be performed. So the objective of this study was to assess our institution's patients' clinical presentations, operative findings, and surgical treatment outcomes for patients with venous thoracic outlet syndrome. And this was a retrospective study. 266 consecutive patients between the years of 2016 and January of 2022 were studied. And what follows are several demographics, but I will highlight what interested me the most, or what I was most curious about. Like other published studies, the right side was affected more often than the left, and very few had bilateral symptoms. What's important is their timing to presentation, as we will see later, looking at acute, subacute, and chronic. And this is the timing from their symptoms to their either initial venographic evaluation, often performed by an interventional radiologist to perform thrombolysis, or their office visit in the cases where this was not done and they were placed on anticoagulation alone. As you can see, approximately half of our patients presented acutely, which is within 2 weeks, and the other half either subacute or chronic, 2 weeks to 3 months or greater than 3 months. Now, looking at the patients who did have a initial venographic evaluation performed, we see that nearly 70% were amenable to an intervention, such as either thrombolysis or balloon angioplasty, while 30% were not. And these are several cohorts we will evaluate further later in the presentation. As far as timing to office visit and operations, this was in line with other published reports, including with what we saw from our friends at St. Joseph. We wait about 4 to 6 weeks after thrombolysis often to perform the surgical decompression. As far as our annual operative volume during our study period, about an average of 40 cases per year. Age distribution, you see, again, our mean age was 32, most of those patients presenting, fortunately, acutely. As far as if we can assess an etiology of the thrombosis, more often than not we could, with about 40% of the patients having some sort of athletic predisposition, either competitive or recreational. And just looking at the far left, median time from symptom onset to their initial venographic evaluation was 14 days. And I'll pause here on this slide, and as you can see, and as other published studies have shown, that when you present acutely, you are more amenable to either a thrombolysis or angioplasty. That doesn't mean that those who present subacute or late should forego this venographic evaluation, as some of those patients were also able to undergo thrombolysis and or some sort of balloon angioplasty. And now looking at our outcomes, first by age distribution, we see that overall for our 266 patient cohort, 150 of them had a patent vein at the end of our operation with our venogram, so the venolysis alone sufficed. We see that 10% had chronic occlusion, not amenable to any sort of venous reconstruction. And about 40% or 34% either had a patch angioplasty or a bypass performed. Nothing was statistically significant when looking at age distribution. However, as I said, we would explore their presentation from symptoms, looking at acute, subacute, and chronic. And one of the first interesting things we see is that those who had a chronic occlusion, not amenable to any sort of venous reconstruction, had an equal distribution of either presenting acute, subacute, or chronic, hinting that perhaps their fate is written in stone. But there was statistical significance when combining our venous reconstruction, and that those who did present subacute or chronic were more likely to require either a patch angioplasty or a bypass graft. And these two graphs also show that statistical significance. On the left, we see that approximately 44% of our patients who didn't have a prior thrombolysis or angioplasty required a form of venous reconstruction, compared to 30% who did have thrombolysis or angioplasty. And we're looking at outcomes. The primary outcome we focused on was persistent arm swelling at our median of 7.8 follow-ups, and 12% of patients who did not have any initial venographic intervention did have arm swelling, compared to 5% who did not. And finally, our overall outcome slide divided by surgical treatment cohort. It is no surprise that the group who had a venous reconstruction had a longer operative time, hospital stay. 20% of those with a bypass graft did have a early reoperation, either for a hematoma evacuation, more often than not. Looking down at our primary outcome for arm swelling, we see that looking at the widely patent group compared to both venous reconstructions, 90% had no arm swelling at the end of follow-up, and our overall cohort, 93% of patients had no arm swelling. But as you can see, that chronic occlusion group, 70% did not, so 30% did have persistent arm swelling. And all but 6% of patients were off anticoagulation at the end of our follow-up period. So in terms of conclusions, with our protocol of paraclavicular decompression, external venolysis, and possible venous reconstruction, we see they have greater than 90% clinical outcomes that were favorable. As we know, and it's important to further express this because we are now at the first line as vascular surgeons for patients presenting with arm swelling, for our ED colleagues, for our family medicine colleagues, early recognition and prompt venographic evaluation does show significant improved outcomes. And finally, I would say that those who do present without this initial venographic evaluation, either in a subacute or chronic fashion, more often than not, those for our cohort required some sort of venous reconstruction. And as such, they might be better amenable to the paraclavicular exposure, where this type of venous reconstruction is already exposed and able to be performed. I want to thank everybody, and I'll take any questions at this time.
Paper's open for discussion.
I actually have a question. What conduit are you using in the bypass candidate?
Cryopreserved vein.
So yeah, in my practice, the patients who are the chronic or the subacute ones are the real challenges. I find the durability of them, it's just a marked difference. It's 90% for the acutes, and it's probably 50-50 for the chronics. My question is, there are times when we want to refer patients to WashU, and the question is, what are you doing with patients who are kind of minimally symptomatic but are subacute? The younger player, tennis player, whoever it may be, they have some symptoms that they're subacute, and I've always been kind of the opinion that they have some collaterals probably, and the risk of compromising those collaterals through a major surgery is going to be significant, but I don't have the experience because we don't do that, and many people don't, so I'm curious what the thoughts are on that.
For these oligosymptomatic patients who once presented with severe symptoms, it might be slightly improved either with some sort of thrombolysis or anticoagulation. Just like was spoken earlier, we still will perform decompression. One, they might be amenable to a bypass or patch, but two, if not, we're hoping that the collaterals that have formed will have better outflow with the decompression. So we would still prefer to proceed with an operation.
70% of the chronically occluded after just venolysis had no arm swelling, right?
Correct.
And 40%, or I can't remember now, you said how many did not require balloon angioplasty after just venolysis as well. So why do the angio at the same time as your initial surgery?
We do the angio at the same time to see if we should perform either the patch or the bypass. We might just, if we didn't have any sort of venographic visualization at the time of decompression, we might be leaving behind some sort of a focal stenosis. And other protocols treat that focal stenosis with balloon angioplasty, for instance. And so it's sort of a comparable group to our institution where those are performed with a patch. Am I understanding your question correctly?
Yes, thank you.
Okay.
We'll continue this. I'll find you afterwards.
Sounds good. Thank you.
All right, thank you.